You can be losing your vision right now and feel absolutely nothing. No pain, no blur, no warning. That's the uncomfortable truth about glaucoma. It usually doesn't start by making your vision fuzzy. It starts by deleting your side vision quietly, and you can still read the 20/20 line in the center of your vision while the damage is piling up. And here's the part that fools smart people. Your brain covers the missing pieces so well that you'll trust a false picture of the world. In a minute, I'll show you how that trick works. But first, I want to talk about what glaucoma actually is. Glaucoma is damage to the optic nerve. That's the cable that carries visual information from your eye to your brain. So when people say, "I'd know if my pressure was high," they're mixing up a risk factor with the problem itself. Eye pressure does matter, but the thing we're trying to prevent is damage to the optic nerve. And nerve damage in the eye doesn't come with a built-in alarm system. I think a simple model helps explain this. Your eye is constantly making a clear fluid inside of it. Think of it like a sink with a faucet running all day. Fluid is produced, it circulates, and drains out through a tiny drainage system. When the drain can't keep up with the faucet, pressure can build up. That pressure over time can stress the optic nerve and the nerve fibers that make up your retinal nerve fiber layer. Now, you might be thinking, if pressure rises, shouldn't it hurt? Well, usually it doesn't. Pain happens when certain tissues get irritated or inflamed, like the surface of the eye with dryness, or a scratch, or even an infection, or when pressures rise suddenly and dramatically. But the most common form of glaucoma is something called open-angle glaucoma, and it's typically slow and quiet. The pressure can be high for you without being high enough, fast enough to trigger eye pain. And the truth is that you can't feel the difference between normalish and borderline high pressure in the eye, much like if you could feel a splinter in your finger. And it's even more deceptive because not everyone with glaucoma has high pressure at all. In fact, some people have what's called normal tension glaucoma or even low tension glaucoma, where damage happens even though the measured pressure in the eye looks normal in the clinic setting. And that's one reason glaucoma isn't diagnosed by a single number. It's diagnosed by a pattern, risk factors, optic nerve appearance, structural measurements, and functional visual testing over time. Now let's separate the two big buckets you'll hear about because people get these confused and it can create bad assumptions. Open-angle glaucoma is the common one. The drainage angle is technically open, but the outflow system isn't working efficiently. Think of it like a drain that's not clogged by a big chunk of food, but it's slowly getting gunked up over time. This version usually progresses slowly. No pain, no redness, no dramatic event that forces you to go to urgent care. That's why this condition can get missed. Now, acute angle closure glaucoma is different. In some eyes, the anatomy of the eye is crowded, and the drainage angle could become narrow or closed. When it closes suddenly, that can be an urgent situation and can cause significant symptoms. But here's the key. I'm not teaching you to self-diagnose angle closure. I'm not teaching you to assume that no pain means no risk, because the glaucoma most people end up with is the quiet one. Now, the second myth that keeps people complacent is the vision chart. The eye chart is a central vision test. It's like checking the very middle of your camera sensor and declaring the whole camera is fine. Glaucoma usually attacks the peripheral vision first. This means that you can read, text, work on a computer, and still be losing your functional safety buffer, the vision that helps you notice things off to the side, judge space, and detect movement. This is why someone can walk into my clinic and say, "Hey doctor, my vision is great," and they're not lying. Their central vision can be very sharp, but their optic nerve can show thinning and even pallor, and their peripheral vision can have gaps. So glaucoma is not a blurry vision first disease. If you're waiting for blur as your warning sign, you're waiting far too long. And now I want to talk about 3 more misconceptions that I also hear about quite frequently. Number 1, I'd know if my eye pressure was high. No, you don't have pressure sensors that give you a reliable symptom. Most people with elevated pressure feel normal. It's only when the pressure goes suddenly high that you feel anything. Number 2, I just had the air puff test, so I'm cleared. Well, the air puff test does measure pressure, and it can be useful, but it doesn't evaluate your optic nerve in detail, and it doesn't map your peripheral vision. A normal pressure reading today doesn't guarantee you won't develop glaucoma later, and it doesn't rule out glaucoma right now. Number 3, if it was serious, I'd have blurry vision. Glaucoma is serious, and because it can be advanced before blur shows up, it's very important to take this seriously. Central vision often stays sharp until it's late. So here's a reality check. Glaucoma is a slow injury to the optic nerve. It's usually painless. It doesn't announce itself with obvious blur, and it can be happening while you're still functioning normally. And now that you understand why you don't feel it, we need to talk to you about why you also don't see it, because your brain is going to help hide glaucoma from you. So early glaucoma doesn't look like a black curtain sliding in from the sides. Most people never see darkness. What you experience is a believable, edited version of a world that feels complete. That's why glaucoma earns the nickname silent thief. It steals, and your brain quietly covers the tracks. Your visual system is not a security camera recording raw footage. It's more like a live editor trying to deliver a stable, useful picture. The thing most people miss is your brain is constantly making guesses. It smooths, it predicts, and it fills in gaps. That's normal, and most of the time, it can be very helpful. But when glaucoma starts creating small blind spots in your peripheral field, that same helpful system can become a liability. So how does the filling in happen? Well, first, your brain uses nearby patterns. If a small area of vision is missing, the brain tends to extend colors, lines, and textures from the surrounding area to help fill in the gap. It's like patching drywall. If the hole is small and the paint matches, you don't notice the repair unless you're hunting for it. Second, your brain tends to use your other eye. Most of your day is spent with both eyes open, and the overlap between the two eyes is very significant. If one eye has a defect in a certain area, the other eye may still cover for it, and your brain merges the two inputs into one story. That combined image can look fine even when one eye is quietly losing ground. And third, your brain prioritizes central tasks. Reading, faces, screens, those live in the center of your vision. So your attention stays locked on what looks sharp, and you don't naturally audit the edges. You can lose a surprising amount of peripheral sensitivity while still feeling visually confident. And this is where real life can get risky. Peripheral vision is your early warning system. It's what helps you detect motion, notice a cyclist, spot a curb, track a step, or catch a hand reaching in from the side. When that system thins on you, you often don't feel blind. You just start compensating. You turn your head more. You scan rooms without realizing it. You walk a little wider around obstacles. You rely on familiar spaces and good lighting. And because these compensations work, you may tell yourself, see, I'm fine. Now, you might be thinking, okay, I'll just cover one eye at home and check. And you can try, but I want to set expectations. Casual self-tests are often unreliable, and they often give false reassurance. And here's why. 1, your brain adapts fast. If you cover one eye and look around, you're still using a brain that's excellent at filling in gaps. 2, lighting changes everything. Peripheral defects show up more in low contrast in dim conditions, and most people don't recreate that at home. 3, you don't know what you're missing. That sounds obvious, but it matters. If your brain has been patching an area for months or maybe even years, you don't have a before image in your mind to compare it to. So what do people notice when it's later? Well, they can be bumping into door frames or cabinets on one side, missing objects on a counter unless they scan, trouble navigating unfamiliar stairs, feeling less comfortable driving at night, or being startled by someone approaching from the side. But none of these symptoms scream glaucoma. They just feel like clumsiness, distraction, or some people say like they're getting older. And that's why glaucoma can slip through. This clicked for me when I started explaining glaucoma like bookkeeping. Early on, the errors are small and the brain rounds them off. Everything still balances. But as more nerve fibers drop out, the rounding stops working. Eventually, the gap becomes too large to hide, and that's when a patient finally says something's off. Now, I need to be very clear, the most important expectation in this whole video. Glaucoma damage is permanent. When optic nerve fibers are gone, they don't grow back in a way that you can rely on clinically. So the goal of treatment is not to restore deleted vision. The goal is to stop further loss and keep what you have for as long as possible. Once you understand that, once you accept that your feelings and your day-to-day perception can't be trusted to catch glaucoma early, then the next step is very obvious. You need objective measurements that can detect the damage, and track the change over time. So let's talk about what actually catches glaucoma early. The goal isn't to pass one test. The goal is 3 things: find your risk, detect damage early, and then track change over time. Glaucoma is a trend disease. One snapshot can look fine. A timeline tells the truth. So the first tool, eye pressure measurements. This includes the air puff, the more accurate blue light test where we numb the eye. Pressure is useful because it's a major risk factor and it's one thing we can reliably lower. But pressure alone doesn't diagnose glaucoma, and normal pressure doesn't give you immunity. Second, a careful optic nerve exam. This usually happens through a dilated pupil. Your doctor is looking at the shape of the optic nerve, the cup inside it, the rim tissue, and whether anything looks asymmetric between the 2 eyes. Just as important as what it looks like today is whether it's changing compared with prior eye exams. That's why old records matter. Third, OCT, which stands for optical coherence tomography. This scan is what measures the thickness of the retinal nerve fiber layer and related structures. In plain language, it's a way to measure your wiring. You can't feel wiring thinning, and you often can't see it in daily life, but an OCT scan can document it and give you a baseline. The thing most people miss is that a baseline is gold. If you only start scanning after you're already suspicious for glaucoma, you've lost years of comparison. 4, the visual field test. This is the test where you look into a bowl and click when you see lights. It's checking function, not structure. And it's normal for it to feel frustrating at first. It takes practice. Fatigue matters, and results do vary. But when it's repeated over time, patterns often emerge. And often, structural thinning shows up before obvious field loss. But the field test tells us what your vision is doing in real life today. And 5th, angle assessment. When appropriate. If you have risk factors for narrow angles or your anatomy suggests crowding, your doctor may check the drainage angle more directly. This helps separate quiet, slow risk from this anatomy could close risk, and it guides prevention. And here's what I want you to ask for calmly and clearly at your next exam. Ask, do I have glaucoma risk factors, doctor? Then mention family history. Ask, how does my optic nerve look, and is there asymmetry? Do I need an OCT baseline in a visual field test, or do I already have one on file? And if you've been told you're a glaucoma suspect, what's the plan to monitor change and how often? One normal visit doesn't rule glaucoma out forever. Consistent follow-up is the safety net. So the key takeaway from this video is simple. You won't feel glaucoma early, and you often won't see it because the optic nerve fails quietly and your brain patches the gaps. It's very important that you get your routine eye exams and follow up with your doctor for monitoring of your vision and overall eye health. So please give this video a thumbs up if you're considering sharing it with any family or friends, and hit that subscribe button. Not only will you become part of our growing community, but you'll also be the first to know when the next video drops. Thanks for watching. I'll see you in the next video.